Hi guys, this is Dr. Patil here, and in this video we will be discussing the recall questions of the recently concluded INI SS Nephrology. Okay. Now the main reason why we are doing this recall session is not for finding out the right answer. I understand we definitely want to know the right answers for all the questions, but you guys should be aware that the recalls are not always perfect, especially when the questions are lengthier these days. Recalls may not be always perfect. So the real question may be something different, and the one that we would be projecting may be totally different, or it may be making different sense. And the answer would definitely change for even a slight change in the wordings. So we should be aware about that, right? The main reason why we are doing this recall session is to identify the patterns in examination. Now examinations also follow the trend, right? So the whole world follows trend today, right? So be it YouTube, be it Instagram, everything it is about trend nowadays. So even exams follow trend. Identify the trend, and your 30% headache is over with that. Right? What are the topics that are becoming more relevant? What are the topics that are becoming obsolete? And once those topics which are becoming relevant, right? What is the level that the examiners are playing at? Whether it is too deep, whether it is relatively superficial, right? These are the points we should learn from the recall session. Right? So without wasting time, let us begin with the first question. So again, I remind you, we are talking about the nephrology INI SS, right? So this is not from the medicine stream, this is from the proper SS stream. Okay, so here is the first question. Not a component of Pkd score. Options included hypertension less than 35 years, hematuria less than 35 years, Pkd1 truncating mutation, and rate of increase in kidney size. This question, those who have followed the NEET SS videos of Dr. Ganga from the PrepLadder, this was not a difficult question because she had covered this point at length. In fact, she had also taken up a clinical examination, a clinical example, and had discussed how we apply the Pkd score, right? So let me tell you that this scoring system is used for ADPKD patients to assess their rate of progression towards ESRD, right? Whether they are likely to develop ESRD before 60 years of age or after 60 years of age. This is the point we want to understand. That is why we are using this Pkd score, right? Okay. Fee-Halley and Brenner's do not cover this scoring system at length, but Dr. Ganga had made it a point that she has covered it beautifully. Right? We will address this question after taking one more question about the same topic, that is ADPKD. Right? Extrarenal manifestations of ADPKD are all except pericardial effusion, male infertility, female infertility, and seminal vesicle cyst. This is also kind of an anticipated question because we know extrarenal manifestations of ADPKD are definitely a hot topic for MCQs. Not only for NEET SS, they are important topics for the routine discussions in undergraduate studies as well as for NEET PG. Okay, I do agree that mostly if they are talking about extra-renal manifestations of ADPKD for NEET PG, it is about what is the most common site where you find cysts outside of the kidney, right? But then at least the topic is relevant for sure, so we could have anticipated these kind of questions. So we will come back to these questions after taking a little bit of learning of ADPKD. As the name says, ADPKD is an autosomal dominantly inherited disease where there is cyst formation in the kidneys. So in ADPKD, the cysts can occur both in medulla as well as cortex, right? Cortex and medulla both can develop cysts. And this disease is due to, we have identified two mutations as of now, Pkd1 and Pkd2, right? And the difference between the Pkd1 and Pkd2 mutation, especially with respect to the rate of progression to ESRD, is again an important MCQ area, right? So Pkd1 usually codes for polycystin 1, and this is associated with relatively rapid progression to ESRD. So the median age of onset of ESRD is usually under 60 years for Pkd1 mutations. For Pkd2 mutations, it is associated with, it codes for polycystin 2, and it is associated with relatively slower progression to CKD or ESRD. So the median age is around 70 plus, right? Not before 60 years for sure. Okay, so this is one important MCQ area. Now, coming to the clinical features of the ADPKD, some MCQs can be asked here also. Right? So, median age I have already covered for Pkd1 50 to 55, that means less than 60 years, and 70 plus for Pkd2. Right? They can ask you what is the most common clinical manifestation of polycystic kidney disease. Well, I do agree, there are cysts, so hematuria can occur, patients can experience pain, patients can develop recurrent urinary tract infections, and patients can progress to ESRD, right? But the most common manifestation is hypertension. So this is a NEET PG level question in fact, right? The most common manifestation is hypertension. Now I also want you to remember that when I talk about recurrent UTI in patients with ADPKD, right? Remember, ADPKD carries the highest risk of urinary tract infections or recurrent UTIs among all the cystic kidney diseases, right? So we have ARPKD, ADPKD, tuberous sclerosis, nephronophthosis. So there are various disorders where renal cysts are known to occur, including modified. Right? The highest risk of developing urinary tract infection is with ADPKD. Right? This is also a potential MCQ point. Now coming to the extra-renal manifestations. Right, we guys are all familiar. Liver cysts are the most common extra-renal manifestation, right? And liver is the most common extra-renal site for development of cysts. This is all known fact. Up to 80% of the patients you may see liver cysts, right? But cysts can also occur outside of the kidney and liver, right? Those common sites we should be familiar with. Seminal vesicle cysts are known to occur. Cysts can occur in prostate. Pancreas cysts are very common, and arachnoid cysts can also occur. Brain per se doesn't develop cysts, but arachnoid cysts are known to occur. Other than that, cysts in these locations, patients are prone to develop mitral valve prolapse, aortic regurgitation, and colonic diverticulate, right? So these are the extrarenal manifestations. Okay. Now coming to its diagnosis, right? So for diagnosis, currently we follow something called as Unified Ravine Criteria. So the name of this is also a potential MCQ point, so I want you to remember, right? So we have Unified Ravine Criteria. So in fact, Ravine Criteria, Fee-Halley gives it in 3 sections. The first one is what actually originally proposed. Then we have this unified or modified Ravine criteria, which is currently used for the diagnosis of ADPKD. But when you want to exclude the diagnosis, there is also a separate set of criteria. Now, what is this criteria all about? This criteria is all about doing an ultrasound, identifying the number of cysts, and then deciding whether it fits into the profile of ADPKD or not. Why that is relevant? Because with aging, right? So normal people also may develop some cysts in kidneys. Whether it is relevant, age matched, or whether it is out of proportion. That is what we are trying to identify using the Unified Ravine criteria, right? So the investigation here is ultrasound, not MRI or CT. Definitely MRI is a better investigation, but ultrasound is more convenient to use, so that is what we are using here. So if the patient's age is between 15 to 39, then we need to show that there are at least 3 either unilateral or bilateral kidney cysts, right? So there are at least 3 unilateral or bilateral kidney cysts. So bilaterality is not mandatory at this point when the patient's age is between 15 to 39. Right? When the age is 40 to 60 or 40 to 59, in that case, bilaterality is must. So each kidney should have cyst, and each kidney should have at least 2 cysts. As I told you, aging in normal person also, more cysts are appearing. So we have to have a number which is higher than expected for the age. Right? And when the patient's age is more than 60 years, at least 4 cysts in each kidney. So again, bilateral, 4 in each. So we need 8 cysts in these patients, and we need 4 cysts in patients with 40 to 59 years of age, and we need 3 cysts for patients between 15 to 39 years of age. Okay? So this is the Unified Ravine criteria. If you are following Fee-Halley, this is the table which summarizes the ultrasound criteria. Right? So it has also a criteria laid out for revised diagnostic criteria when the diagnosis needs to be excluded, right? So in the age range of 15 to 29, right, if there are no cysts, the diagnosis is almost excluded. Right? This says that these are the minimum number of cysts you should be seeing to think or keep the possibility of ADPKD open. Right? When these numbers are met, the diagnosis is certain, or you can strongly consider. But when those numbers are not met, you can still keep the diagnostic possibility open. You don't exclude when there are more than or equal to 1 cyst in the 15 to 29 years age group. If it is 0, the diagnosis is excluded, right? That is the utility of this system. 30 to 39 years of age, again 0, the diagnosis is excluded. 40 to 59 years of age, 1 or 0, the diagnosis is excluded, right? 2 or more than 2, the diagnosis is open. When there are more than 2 in each kidneys in this age range, the diagnosis is kind of confirmed, right? So when the patient age is more than 60, 3 or more than 3 cysts in each kidney, the diagnosis is open. But for the definitive diagnosis, we need 4 or more than 4 in each kidney, right? When there are 1, 2 or 0 cysts at this age group, the diagnosis is excluded, right? So this is the basic Ravine criteria, right? So currently for diagnosis, we are using this Unified Ravine criteria, and when the diagnosis needs to be excluded, we still have some parameters to keep in mind, right? So, and the investigation that is used here is ultrasound, not the CT or MRI. Okay. Now coming to the real area of interest, right? The question was about PropKD score. So as I told you, PropKD score, we were anticipating questions related to that. So whenever we study about scoring systems, the first point I always tell you, first layer of understanding or first layer of information that we should assimilate is the component of the scoring system. What are the components that go into the scoring system? The second layer of understanding is how to apply that and whether I should really know the individual scores assigned. So individual scores are not mandatory for all the scoring systems. The scoring systems, according to me, are like relevant if it is a very common disease. For example, if I am talking about neurology, right, the scoring system that are used for stroke, intracranial hemorrhage, or scoring system that is used for making a decision about anticoagulation in patients with atrial fibrillation. Those are quite commonly used scoring systems. They have a day-to-day utility when you are a practicing physician or a super specialist. So those scoring systems, yes, you should know the individual scores. If it is about SLE or rheumatoid arthritis, very common diseases, hot topics for MCQ. So there are also classification criteria, the scores I want you to remember individually. Do I want you to remember the PrepLadder scoring systems individually? If you are for the central institutes, yes, now that they have already asked one question about it, now this is going to be a relevant topic for upcoming examination. But if you are preparing for NEET SS, then I don't want you to waste your time trying to remember each and everything about this, right? Okay, you just know about the PrepLadder scoring system and little bit points about the prognosis. Okay, so what are the components of this PrepLadder scoring system? Being male, hypertension before 35 years of age, first urological symptom. In the question that we were discussing, hematuria was mentioned. It can be considered as a first urological symptom before 35 years of age. And when it comes to mutation, Pkd2, patient is getting 0 points. Right? Then non-truncating Pkd1 mutation and truncating Pkd1 mutations. These are the components. As I told you, this is the basics I want you to remember if you are preparing for the INI SS. Right? Okay. And what is the utility of this scoring system? To decide or to understand the risk of developing ESRD before 60 or after 60, right? So we are assigning these score points, and after that, if the score point is less than 3, right, we can say the low score, and the chance of development of ESRD before 60 is virtually nil, right? Almost close to 0 until and unless there are other risk factors, right? So the median age of ESRD in these patients is usually 70 plus, right? On the other hand, the score range of 4 to 6 is considered as intermediate, and mostly the patients, the median age of onset of CKD or ESRD in these patients is around 60 years, approximately 60 years, right? When the score is 7 to 9, we can consider it as a high score or a high risk score, and the median age of ESRD onset in these patients is 40 to 50. 49 is the median age. So that means these patients, where score is 7 plus, right, they have the highest risk of developing ESRD before the age of 60 years, right? And this is, I have quoted from one particular study where the positive predictive value of this finding was 90% plus, right? So that is the utility of the PrepLadder score. Now those who are preparing for INI SS, now that we know this is a very relevant topic, right? You have to apply the scoring system for clinical MCQs and be able to come out with a score so that you can predict the risk of ESRD in those patients before 60 or after 60, right? So in this case, there is an example here. 29-year-old male with hypertension and truncating Pkd1 mutation. And so this patient, male gender is considered as a risk factor. So generally males have a little rapid progression towards ESRD in comparison to females. So for that reason, we will be giving 1 point for being male, right? Patient is having hypertension before 35 years of age. Right? That was one of the scoring systems. So we are giving 2 points for that. So patient gets 2 points for that, right? And then the Pkd mutation. Now I want you to remember that Pkd mutations, right? I did tell you that Pkd2 has low risk of progression to ESRD. The median age of ESRD onset is 70 plus. So we are giving 0 points for that. Right? On the other hand, Pkd1 mutation, higher risk. So when there is a Pkd1 mutation, we are giving some points for sure. Right? And we all know that the truncating Pkd1 mutation is associated with high risk of ESRD progression in comparison to the missense or the non-truncating Pkd1 mutations, right? So for that reason, for non-truncating Pkd1 mutations, we are giving a point of 2, and for truncating Pkd1 mutations, we are giving a point of 4, right? So truncating mutation is associated with higher rate of progression, 4 points. Again, one more important point to remember. So in this case, they have mentioned that this patient has truncating Pkd1 mutation, so we are giving 4 points. So cumulatively, this patient has 7. So that is a high risk, right? So this patient's chance of developing ESRD before 60 years is quite high, right? Okay. So we could predict that this patient may develop ESRD before 60 years using the PrepLadder score. Okay. Now with that, let us go back to the question and address the points that we needed to know. Not a component of PrepLadder score: hypertension, discussed, less than 35 years, hematuria, right? The first urological complaint before 35 years of age. Hematuria is mentioned here. So this is also a component, true point. Pkd1 truncating mutation, right? True, it is also a component. Even if they had mentioned non-truncating, that's also a component. And even if they had mentioned Pkd2 mutation, that's also a component. We are giving a score of 0, but it is mentioned, it is covered in the scoring system, right? So I would be considering that as also a component until and unless the other three options are more relevant and the Pkd2 mutation is the least relevant point, then I would be opting that as an answer, right? Otherwise, that is also a valid point. Now, the rate of increase in kidney size is not a component of the PropKD score, right? So this is not a dynamic scoring system where the rate of progression is also taken into account, right? This is like a flash scoring system. Okay, so the rate of kidney increase in size of the kidney correlates with the risk of progression towards ESRD, right? And this we can say based on the CRISP trial. So those who are preparing for the INI SS, go through this CRISP trial and take home important messages, right? So the name of that study is CRISP study. Okay, and that was an MRI based evaluation, not the USG, right? So USG was not used for assessing the rate of progression of the kidney size. MRI was used. Okay, so the right answer for this question is obviously option D. Now the next question was about extrarenal manifestations, right? So we all know the most common extrarenal manifestation is liver cyst. We have just discussed about it. Now coming to the options here, right? Let me begin with option D, seminal vesicle cyst. I have already told you that seminal vesicle, prostate and arachnoid cysts are known to occur. So this is a true statement. Definitely it's a component. This is an extrarenal manifestation. Okay, and this explains indeed male infertility, right? So male infertility is also a extrarenal manifestation of ADPKD because patients have seminal vesicle cysts. Okay, so this is true. This is true. We are left with pericardial effusion and female infertility, right? Pericardial effusion, there are some sources including Brenner and some other texts do mention pericardial effusion as one of the extrarenal manifestations. So let us assume it as a true statement. And there is no direct explanation for female infertility in patients with ADPKD. So whenever you have a ADPKD patient who is female and there is infertility, you have to evaluate for other causes, right? So that point is clear. So the right answer for this is option C. Okay, now let us go to the next question. So this is the next question, again related to a cystic kidney disease. A male teen, right? So please note the age clue is given, right? So male teen we are talking about. The gender clue is given, age clue is given. I don't know if the particular teen age range was mentioned, whether they told that this was a 14-year-old or a 15-year-old patient, or whether they had only mentioned the word teen. Most students said that they had mentioned about teen. So let us assume that they had mentioned the question is about a male teen. Presented with a creatinine of 3.6 milligrams per deciliter and on USG, kidney size was normal or kidney was normal. I don't know exactly the wordings, whether they had mentioned the size was normal or kidney was normal. Irrespective of that, morphologically, we didn't see anything grossly abnormal in ultrasound. That message was loud and clear. Patient was positive for NPHP1 mutation. So NPHP1 mutation was present. The question was asking if the biopsy of this patient is taken, the kidney biopsy is taken, what is the most likely observation you will get on the biopsy specimen? Options included tubular basement membrane irregularities, podocyte loss, interstitial fibrosis and tubular atrophy. Some student did tell me that this option C was about interstitial fibrosis and tubular atrophy only. That means no other manifestations you are expecting. And glomerulomegaly with oligomeganephronia. These are the options that were given by the student. Now, this is very clear to us, right? This is a question about nephronophthosis, right? This is a question about nephronophthosis. Now, one important point about this is that they had mentioned NPHP1 mutation, right? So we all know that means it is a juvenile nephronophthosis case, right? So NPH2, 3, so we almost have around 20 NPHP mutations identified in patients with nephronophthosis. Right? Typically NPHP1 is associated with juvenile onset nephronophthosis, right? The NPH2 and 3, they are classically associated with the onset between the age of 0 to 5 years, right? Okay, so now we are dealing with a case of nephronophthosis. To be more precise, juvenile nephronophthosis. Now, Feehally and some other resources mention that this term juvenile and infantile onset, these are to be abandoned because there is no gross such phenotypic variation actually observed with these mutations. But the same authors do give a table where they mention that the variability or differences between these NPHP1, 2, 3 mutations So from the exam perspective, we still need to pay attention to this area, right? Okay. So now we know that this is a case of nephronophthosis. So we will learn some points about nephronophthosis and come back to this question. Nephronophthosis characteristically shares a triad of the biopsy observations. So the triad includes tubular basement membrane irregularities, interstitial infiltration with fibrosis, and tubular atrophy with cyst formations, right? So that means nephronophthosis is also a cystic kidney disease, right? So one of the component of the triad was the option, so that was like a straightforward answer, right? So even if you are following the fee Halley, he starts his opening statement about this disease itself begins with this point, right? Tubular basement membrane irregularity. He talks about this triad. He tells that this triad is shared by another disease called as medullary cystic kidney disease, which is currently called as autosomal dominant tubular kidney disease, tubulointerstitial kidney disease, right? Okay. So this triad and the differentiation between the medullary cystic kidney disease and nephronophthosis, right? This is an important area for MCQs according to me. So spend some time trying to understand the differences between these two, right? That emerges as an important topic. Okay, and there is also one important table in the fee Halley which is about the features of renal cystic diseases in children. So he summarizes most of the cystic kidney diseases, their relative features, or I can say the whole chapter is summarized in this table, right? And from this table, 50 MCQs can be asked, or 50 MCQs can arise from this table. So this is a table which I want all of you to spend 4 to 5 hours solidly, or multiple exposures of this table, 35 minutes at every occasion, so that every point that is covered in this table is registered in your mind. Okay, so from the table what we learn about nephronophthosis is the NPH2 and 3 mutations, the usual age of onset is 0 to 5 years, right? So this point I have already told you. And the NPHP, particularly 1 mutation, it is usually juvenile, right? 0 to 18 years of onset, right? Then the other thing we learn about is the kidney size. So NPH2 mutation is associated with enlarged kidney size. NPHP3, some cases, yes, right? NPHP1 particularly, it is not associated with enlarged kidney size. So that observation is consistent with what the question was talking about. In the question, the ultrasound, it was mentioned that the kidneys are normal or normal in size, right? So we are consistently leaning towards the diagnosis of juvenile nephronophthosis in that MCQ. Okay, and when the pathology is taken into account, right, NPH2 is associated with multiple cysts, and the NPHP1 is typically associated with few cysts, usually at the corticomedullary junction. Now, I had also told you that the cyst infection risk, right? So this table also summarizes that point. So cyst infection is quite common in patients with ADPKD, right? As you can notice here, cyst infection occurs frequently. It is uncommon in ARPKD, it is uncommon in Immunoglobulin Syndrome, it is kind of uncommon in patients with tuberous sclerosis, and it is almost not known to occur in nephronophthosis, right? So nephronophthosis is not a direct risk factor for urinary tract infections or cyst infections. If there are other risk factors or if there are exposure, it can occur, right? Okay. Now, in terms of the hypertension risk, right? So BP typically in NPHP1 is likely to be normal. Hypertension risk is higher in patients with NPHP2 mutations. That is one more point we learn. Now, the other point you should know also about is the CNS involvement in various cystic kidney diseases, right? So there are 3 cystic kidney diseases where there is a risk of CNS involvement. That includes nephronophthosis, where there is usually cerebellar vermis aplasia, right? Cerebellar vermis aplasia, which is known as Jawbird Syndrome, right? So MCQ can be asked about which of the following cystic kidney disease is associated with Jawbird Syndrome, that is nephronophthosis, right? The other conditions where there are cysts in the kidney and there is CNS involvement, that is Meckel-Gruber syndrome and tuberous sclerosis, right? So in Meckel-Gruber syndrome, we see encephalocele and mental retardation, and tuberous sclerosis, you're all familiar. Patients are prone to develop seizures as well as intellectual disability, right? Other than this, yes, you can also anticipate a lot more MCQs from this table, so please spend time with this table, right? Okay, just before we move on, because we were talking a lot about ADPKD, let us see what ADPKD information this table talks about, right? So ADPKD, the clinical onset is usually in older children, but unlikely in infancy. But ARPKD, we know it is typically in perinatal age, so many patients are diagnosed before the delivery itself. Patients also are known to develop Potter's facies. This is also an important MCQ point, right, for about ARPKD. ADPKD, obviously kidney size increases in size progressively. So we all know multiple cysts is something that we all know. Cortical as well as medullary. Cyst infection that carries the highest risk. This point we have already addressed. Blood pressure, yes, as I told you, hypertension is the most common clinical manifestation of ADPKD. So hypertension can occur. Renal function, at least in the pediatric age group, is going to be normal. Only later on, the median age of ASRD is 60 plus. So only in the 4th or 5th decade, you will start noticing some renal function decline. Then nephrolithosis, yes, kidney stones can occur in patients with ADPKD, and when kidney stones occur, right, in patients with ADPKD, the most common kidney stone is uric acid stone. This is also a potential MCQ point, right? Uric acid stones are more common than the calcium stones, right? Okay, so we have addressed the important points from this table. Now let us go to the next question. So the next question is asking you, DNA-JB9 is a novel marker for, right? This is kind of an anticipated question because there was a lot of online resources talking about DNA-JB9 as a novel marker for a particular glomerular disorder, right? Okay, and Feehally covered this point particularly when he spoke about that entity, right? So what is this entity about? This should have been an easy question because even the PrepLadder NEET SS videos had addressed this DNA-Jbm mutation. It was covered in the PrepLadder NEET SS video per se. So options include fibrillary glomerulopathy, immunotactide glomerulonephritis, amyloidosis, or MPGN, right? I think one thing that I can rule out straight out is MPGN, because MPGN is more about a pattern of disease rather than a particular one entity, right? So we know like there are various conditions which may be responsible for MPGN, so various other substances may be deposited in patients with MPGN. So option has to be hidden between these three, right? Fibrillary glomerulopathy, immunotactide glomerulonephritis, and amyloidosis, right? So all these deposition diseases, we have to follow this classification system, right? So whether there is a pattern, whether it is organized or unorganized, that is the one broad classification, right? And from Brenner, I got this very beautiful classification of the organized glomerular deposits, right? So organized glomerular deposits based on the Congo red staining, we know that is for the amyloidosis, right? We divide them into amyloid deposits and non-amyloid deposits, right? And the amyloid deposits further based on the immunofluorescence for the light chain and the AA, we are classifying them as AL amyloid or AA amyloid, right? Okay, so that is about amyloid. Now, if the deposits are negative for Congo red stain, right, then it is non-amyloid. So we are again looking for immunofluorescence for immunoglobulins, right? So based on that, positivity or negativity for immunofluorescence against immunoglobulins, right? So if it is positive, we will be classifying them as immunoglobulin derived deposits, and if it is negative, we will be classifying them as non-immunoglobulin derived deposits. The deposits may be because of something else, not immunoglobulins per se, right? So non-immunoglobulin derived deposits include fibronectin glomerulopathy, collagenofibrotic glomerulopathy, and diabetic sclerosis, right? So diabetic is non-immunoglobulin derived, one potential MCQ point, right? Now coming to the immunoglobulin derived deposits, cryoglobulinemia is one, then SLE is another, immunotactoid and fibrillary, right? So it is emerging that the differences between immunotactoid and fibrillary is going to be a hot topic for MCQs for next couple of exams. Those who are preparing for the NEET SS 2021 and 2022, remember this is going to be an important MCQ area. In the past, most of my predictions have turned out to true, right? Whenever I told that this is likely to be a hot topic, it has proven to be a hot topic in the subsequent examination. So I do see that this is going to become a hot topic, right? Differentiation between immunotactoid and fibrillary glomerulonephritis, right? Okay, now before we discuss more, I do see some discrepancy, right? Some faculty members do believe that the size of these fibrils that can be asked as a MCQ, right? But I don't see that coming. Main reason is various resources have mentioned different numbers. So we are actually dealing with a proper super specialty topic, right? So where interpretation of different studies, depending on what you quote or what are your sources when you are writing a book or when you are writing an article, your numbers may vary, right? So the numbers, according to me, should not be a game for MCQs. If at all they're asking, I would recommend still to rely on what Feehally talks about rather than going with Brenner's. Feehally has kind of stood the test of time in the recent years for MCQ based examinations. Okay. Now for this differentiation, immunotactoid versus fibrillary glomerulonephritis, there is a beautiful table in the Fee-Halley, right? Immunological and clinical characteristic of fibrillary and immunotactoid glomerulopathies. So where he is also comparing that with amyloidosis, right? He is comparing with amyloidosis, fibrillary glomerulopathy and immunotactoid glomerulopathy. So as we already know, amyloidosis is going to be positive for Congo red stain. Fibrillary and immunotactoid is going to be negative, right? And we all know now from the previous system that immunoglobulin derived deposits are occurring, right? So that means if the fluorescence study is done for immunoglobulins, it is going to be positive in both cases, immunotactoid as well as fibrillary. Now, one of the main difference at the electron microscopy levels between these two is, in case of fibrillary, name says it all, fibrils are deposited, right? In case of immunotactoid, microtubules are deposited. That is one important difference, right? So fibrils in fibrillary, microtubules in immunotactoid, right? So for microtubules, I want you to remember two causes, right? The one is cryoglobulinemia, where again microtubules are deposited, and the other one is immunotactoid, right? Two, right? Otherwise, most cases it is fibrils, right? Okay. So two conditions for microtubules, right? Cryoglobulinemia and immunotactoid. Now, as I told you, right, I do see discrepancies in terms of the fibril size. So amyloidosis, this table mentions 8 to 15, 12 to 22 for fibrillary glomerulopathy, and it is usually more than 30 for immunotactoid. So anyway, we are talking about microtubules in that case, right? So the deposit size more than 30, typical of immunotactoid, right? 12 to 22, typical of fibrillary glomerulopathy, and 8 to 15, amyloidosis AL type. Right. Okay. Now, when it comes to immunoglobulin deposition, right, the type of immunoglobulin, it is going to be mostly monoclonal light chain in case of amyloidosis. So this point again, the previous class addresses it, right? Okay. Monoclonal light chain, mostly the lambda chains, right? On the other hand, for the fibrillary glomerulopathy, it is mostly IgG4, right? So remember again, the IgG4 is a hot topic for exams these days, right? So usually it is polyclonal and mostly IgG4. It can be monoclonal occasionally, where it might include either it can be IgG1 or IgG4, right? Okay, so fibrillary, it's mostly polyclonal, right? Amyloidosis is mostly monoclonal, right? Immunotactoid, it's mostly monoclonal, right? Where again we are talking about the kappa chain. Now, in terms of the deposit spreading from the mesangium, right? So fibrillary, most common presentation is membranoproliferative glomerulonephritis. For the immunotactoid, the most common presentation is membranous nephropathy, right? That too, atypical membranous nephropathy is the commonest presentation of immunotactoid, and membranoproliferative glomerulonephritis is most common presentation of fibrillary, right? So this is also a point we should note about. Both cases mostly have the nephrotic range of proteinuria. That is a separate story, right? Okay. So these are the important points that you should know from this table. Again, I urge you spend some time, solid time on this table also, because I do see this coming as a potential MCQ area in the upcoming examinations, even for the NEET SS, right? Okay. Now let us go to the next question. Okay. Now before we go to the question, this is a screenshot from the Fee-Halley, and as you can clearly note, Fee-Halley, he has clearly mentioned for the diagnosis of the fibrillary glomerulonephritis, he has clearly mentioned that the DNA Jbm, right, it is emerging as an important specific marker. So diagnosis relies on detection of immunohistochemistry in glomeruli of DNA Jbm, which seems to be a specific marker for fibrillary glomerulopathy. These are the exact wordings of the Fee-Halley. Right? So otherwise, the diagnosis of these diseases depends on the electron microscopy per se, especially when it comes to immunotactoid and fibrillary glomerulopathies. Yes, you can do the immunostaining, immunofluorescence for the presence of IgG, but more details you are going to get from the electron microscopy, because you need the fibril size. But at least for the fibrillary glomerulopathy, we have this specific marker now, right? DNA Jb9. Okay. So let us go back to the question now and see what is the right answer. Right? DNA Jb9, pretty much clear now. We are dealing with fibrillary glomerulopathy, right? So this is the right answer. Okay. Let us go to the next question now. In this question, we have a 25-year-old intravenous drug abuser who developed pedal edema and ascites. Okay. So at this point, we have a long list of differential diagnoses, right? Intravenous drug abuser, they are specifically mentioned. So we have to keep in mind the infections that are transmitted through this route. So HIV, HBV, HCV is something that we should always keep in mind. And inside the nephrology, we always think about HIV, HCV and HBV, right? Now this patient, okay, they have mentioned this patient was positive for HCV. Urine analysis showed proteinuria and hematuria. Okay, so this constellation of symptoms, definitely it's very clear that we are dealing with glomerulonephritis, right? So a drug abuser, HCV positive and glomerulonephritis. At a very higher level, sometimes questions may be centered about the possible drug that is being abused and its renal impact. So that also is something that we should keep in mind. Okay. Now the question is quite straightforward. The final statement of the question is, which of the following is least likely to occur due to HCV in this case? Right. So we have glomerulonephritis, HCV positivity. Right. So which of these manifestations cannot explain this constellation of glomerulonephritis and HCV, or HCV leading to glomerulonephritis? Right. FSGS is one option, polyarteritis nodosa is one option, membranous nephropathy and mixed cryoglobulinemia, right? And I don't know if the membranous nephropathy was there or whether MPGN was there as an option. This was a bit controversial. Some students said it was MPGN, some students said it was a membranous nephropathy. Okay, now coming to the crux of the matter, HCV and kidney. Right? What is the most common manifestation or most common abnormality or the renal manifestation? Obviously, this is an important MCQ point. Most common one is MPGN. We are all familiar with that, right? So you open up any of the sources, it mentions MPGN as the most common manifestation, right? So this point is clear. Most common is MPGN. And MPGN, with that, there is a part and parcel of the manifestation is presence of mixed cryoglobulinemia, right? Again, the most common type that we would be seeing in this patient is type 2, right? Type 2 cryoglobulinemia. Okay, so we all know that is something that comes to our mind when we talk about the extra hepatic manifestations of the HCV, right? Mixed cryoglobulinemia, classically described. Because we all know it also can occur in patients with the hepatitis B. And when it comes to the extra hepatic manifestations of hepatitis B, the first thing that comes to our mind is polyarteritis nodosa, right? And in fact, hepatitis B serological positivity is part of the diagnostic or classification criteria used for PAN. But again, we also know that PAN can also occur in patients with HCV, right? Cryoglobulinemia can occur in patients with HBV, though classically associated with HCV. PAN, though classically associated with the HBV, it can also occur in patients with HCV, right? Okay. Then coming to membranous nephropathy, yes, it has been described to occur in patients with HCV, right? So classical HCV texts do talk about membranoproliferative membranous nephropathy and mixed cryoglobulinemia. So we have to mainly decide between option A and B, whether FSGS is something that we want to go with or whether the PAN that we have to go with. Now, some students did tell me that the other faculty members or somebody told me that, sir, PAN is classically a vasculitic condition. Yes, I do agree with that. And PAN absolutely does not cause the glomerular injury or glomerulonephritis. I don't buy that point. Okay. Now, typically when we, at the super specialty space, no, if somebody says that something is known to occur 100% or something is known to occur 0%, those are little, I mean, you need to take such statements with a pinch of salt, because you will find some case report or something in the digital space which will burst your points, right? Okay, so when someone says that PAN absolutely doesn't cause renal involvement, that's a false statement. But typically PAN doesn't cause renal parenchymal involvement. That is a true statement, typically. Exceptionally, yes, glomerular injury is known to occur. You will find some case reports and you will also find some textbook references, right? So let me quote you one textbook reference. So this is from the Brenner's page number 1118. So here he says, in classical PAN, glomeruli are usually unaffected, right? It is two-story, but atypically it can be affected, right? Okay. So again, Brenner itself in page number 960, he mentions glomerular injury causes, right? So the name of the table is major causes for intrinsic acute kidney injury. So here he's not talking about the vasculature, right? So when he is talking about glomerular injury directly, that to inflammation, he mentions polyarteritis nodosa as one of the causes, right? So that means you can't say that 100% PAN does not involve glomeruli. Glomerular involvement is known to occur. Okay, so that much is basically clear. But the classical presentation of PAN is in the form of aneurysms, right? So that is what we all know. In fact, we all know that PAN, the most commonly affected organ is, this is a MCQ point for rheumatology, for medicine and for nephrology, right? So most commonly affected organ in patients with the polyarteritis nodosa is indeed kidney, right? So kidneys are where you are likely to see the micro aneurysms. Okay, so right now we do agree that glomerular presentation can occur. So it is not something that we can rule out just because there is mentioning of the feature suggestive of glomerulonephritis. And FSGS, well, again, this is one more point we should address. So FSGS can HCV cause? The answer is definite yes. There are a lot of case reports of FSGS that is occurring in HCV patients. Okay, so I will give you some important references. The reference is one recently published mini review article, that is like 2019 review, and this review actually summarizes the kidney and HCV correlation pretty beautifully, right? So the review's author is Andrea Angeletti, and in that review he clearly mentions there is a separate section created for HCV associated FSGS, right? So we know classically FSGS means HIV, that is what we classically know, but HCV can also cause FSGS, right? So there it is believed that the pathogenic mechanisms are maybe something similar to what is happening in HIV patients. So there is virus directly causing the podocyte injury. That is what we believe as of now. So FSGS can also occur, and we know FSGS can present with a nephritic picture as well as a nephrotic picture. Right? So what is the right answer in that case? Well, taking into account that the PAN is least likely to occur in patients with hepatitis C in comparison to HCV, and when it is occurring also, it is least likely to cause glomerular injury and most likely to cause the aneurysms and manifestations related to that. I would like to go with the PAN as an option, but really I'm not sure what is going on in the examiner's mind and based on what studies he has come out with this question. So if you mark PAN, you can't be 100% sure that is the answer and examiner would buy that. Kuch alag hi chal raha hoga in their mind, so the answer may be different also. So I cannot assure you that it is definitely PAN, but if I was giving the exam, I would have gone with PAN as the answer, right? So FSGS, I would consider relevant to HCV. Membranous nephropathy and mixed cryoglobulinemia, no debate about that. So I would have gone with PAN as the answer. Right? Now, before I move on, right, there is also one important table I want to draw your attention from the FIHALI, that is the clinical differences between polyarthritis nodosa and microscopic polyangiitis. Right? So from this also you can anticipate a lot of MCQs. So tables from FIHALI are definitely important. Right? So this is also one of them. So in this table again, what do we learn? Microaneurysms are more common in polyarthritis nodosa, and they are quite rare in patients with microscopic polyangiitis. And this table also mentions that rapidly progressive nephritis, right? So glomerular nephritis, quite unknown to occur in patients with PAN, and it is very common in microscopic polyangiitis. So this also again goes on to say that the nephritis is little less likely with respect to PAN. PAN being less likely in HCV, and then nephritis further being less likely. With all the statistical probabilities for that question, PAN becomes answer according to me. Okay, so guys, again, before I move on, just spend good amount of time on this table. This can generate a lot of MCQs. Okay, so this is the new question. False regarding anti-Gbm disease. Right? Options included pulmonary hemorrhage more common in young females. Hammersmith regimen is used. Severe disease more in elderly females, and elderly patients present with isolated renal disease. Okay, at the outset, for some of you, it might look a bit of a difficult question, but according to me, this is kind of an anticipated question. You guys could have expected this kind of questions to come. I know option B is something which is not heard of so far. Hammersmith regimen is used. So what is this regimen? All of you are probably confused about it. So was I, and all I had to do was ring up a nephrologist friend and ask what is this about. And she told me that Hammersmith regimen is nothing but whatever we currently follow for the anti-Gbm disease in terms of treatment, that itself is Hammersmith regimen. So let me rest it there, right? Let us take this as a true statement as of now. The remaining three options are something that we should be knowing. This is kind of anticipated because we all know anti-Gbm disease has a bimodal age of presentation, right? So we should definitely know the differences between those who are presenting young, those who are presenting older, right? So this is an anticipated area. So if you know those points, if you know the epidemiological points very clear, then this shouldn't have been a difficult question. So let me take you through some basic points about the anti-Gbm disease, and then we will revisit the question. What is anti-Gbm disease? Well, when it comes to this topic, right, there are different terminologies. Goodpasture syndrome, Goodpasture's disease, anti-Gbm disease, all of them mean little different. They are not exact same words, right? So we will first visit those wordings, and then we will come back to this. Okay, so these are the important definitions we should know. We frequently hear this term pulmonary renal syndrome. That means there is renal and respiratory failure co-occurring in a patient, right? So the causes for such presentation, the list is quite long, right? Then Goodpasture syndrome. So Goodpasture syndrome is where there is RPGN and alveolar hemorrhage, rapidly progressing glomerulonephritis and alveolar hemorrhage occurring in one patient. We call it as Goodpasture syndrome. How do we define anti-Gbm disease? It is definitely a pulmonary renal syndrome, right, where there are antibodies specific for any component of the glomerular basement membrane. Right? That is what we call as anti-Gbm disease. So this is one of the pulmonary renal syndrome where there are antibodies specific for a specific component of the glomerular basement membrane are being released. And when that antibody is specific for the alpha-3 subunit, right, alpha-3 subunit of the non-collagenous domain, then we call it as Goodpasture disease. Right? So Goodpasture syndrome is nothing but RPGN and alveolar hemorrhage in one patient. Goodpasture disease is where there are antibody, RPGN is there, pulmonary hemorrhage is likely to occur, or both. It can be isolated also. You can have an isolated lung manifestation, you can have an isolated renal manifestation, or both. But the most important thing is here there are antibodies which are specific for alpha-3 subunit. So anti-Jbm disease means it could be directed against any of the subunits. When it is specifically against alpha-3 subunits, we will call it as Goodpasture disease, right? And then we have this last entity which is Alport syndrome post-transplant anti-Gbm, right? So more of that we will be discussing in the Alport syndrome. Basically, again, this is the Alport syndrome patients developing the anti-Gbm disease after transplantation, right? Okay, so I hope these terminologies are clear. Now let us go back to anti-Gbm disease. So here antibodies are produced against the non-collagenous domain of the type 4 collagen. As I told you, when it is specific against alpha-3, we will call it as Goodpasture disease, right? If you look at the genetics, the HLA-DRB1, we all know that is like the standard HLA variant which is associated with various autoimmune disorders. So DRB1 and DR4 are associated with increased risk. On the other hand, DR7 and DR1 are associated with reduced risk. This is a potential point which can be a MCQ in the upcoming examination. So please remember about that. And another epidemiological point I want you to remember is this is less common in blacks. Right? So comparison to the Caucasians, this is less common in blacks. Now coming to the age of presentation, right? As I told you, it is bimodal distribution. So one peak we see in the third decade, and in the third decade mostly it is the males who are developing the manifestation. Okay, the second peak we see in around 6th decade, right? So older females. So that is 6th decade. The second peak is populated by females. The young males, older females, right? And then in elderly females, the disease is more limited to kidneys, or the initial presentation is isolated renal manifestation. On the other hand, young males present with pulmonary manifestations, right? So that means this is about young males presenting with pulmonary manifestations. So pulmonary involvement is more common in young males, kidney involvement is more common in older females. This is the basic thing, right? The other thing we should also note is the predisposing events that are associated with the Goodpasture disease. So that includes all these vasculitic manifestations. But the thing that precipitates the pulmonary hemorrhage, that also includes cigarette smoking, right? So we all know smoking is more prevalent in males. So young male smokes, develops pulmonary hemorrhage. That's how I can summarize it. So the message is clear. Young males are the ones who are prone to develop more lung involvement in comparison to older females, right? So with this, let us go back to the question and see if we can address it. Option A, pulmonary hemorrhage more common in young females. Well, now we are very clearly knowing that it is young males, not females, right? So this is the false statement and we have our answer. There is one point I want you to note, that there are some case reports of young females developing lung predominant manifestations, but those are isolated case reports. Like generalization cannot be applied to those isolated case reports. Severe disease more in elderly females, true, right? That is true. So the renal Goodpasture has relatively worse prognosis comparison to the isolated pulmonary Goodpasture or isolated pulmonary anti-Gbm. Okay. Elderly patients present with isolated renal disease, this we have discussed. So this is true statement, this is true statement, this as I told you is true statement. So we have our answer, option A, pulmonary hemorrhage more common in young females. Okay, good. So spend some time on the epidemiology of all the rare diseases, because MCQs are being picked up from that point. And all the tables, I time and again stress you, they are important. Right? So this table is definitely important because these terminologies can be converted into MCQs. Similarly, this table is also important, right? Okay, now let us take the next question. A 26-year-old female, a known case of lupus nephritis on steroids, mycophenolate mofetil, and tacrolimus. So she is on 3 drugs. She is a known case of LN. She is on 3 drugs: steroids, MMF, and tacrolimus, and she has defaulted medications. Now there is little bit of confusion when we connected with students and tried to get this sorted out. Some students told me that it was mentioned that she had defaulted medications 6 months after initiation of medications. On the other hand, some set of students told me that it was mentioned that from past 6 months she is in default, or in past 6 months she is not taking medication. That is how the words sounded like. So I'm not sure exactly what it meant. We will try to address it from both perspectives. Now she has a history of amenorrhea for 12 weeks. This is particularly important to pay attention to. 12 weeks means 3 months are over. So the first trimester is over now. Right? And her UPT is positive. So she has already completed first trimester. Her serum creatinine is 1.6 milligrams per deciliter, and urine protein creatinine ratio is 1.8 grams per gram of creatine. Urine routine shows RBC positive. What is the next best step in the management? Now, before we go to the options, right, let us address what are we dealing with here. So we know a female SLE, she had history of lupus nephritis, she was on medications, she has defaulted regardless of the time frame. She has definitely skipped medications, and now she is pregnant and she has completed her first trimester, right? So with that, her serum creatinine is 1.6 and urine protein creat 1.8, and RBCs are positive. So that means she is having the active lupus nephritis, right? So we can also consider it as flare. So she is going through lupus flare. We all know that pregnancy is not generally well tolerated in SLE patients. A lot of complications with respect to mother, a lot of complications with respect to fetus. So what do we do with this pregnancy? The options that appeared in the exam included this: medical termination of pregnancy or discontinuation of the pregnancy is what the words were exactly mentioned about. Repeated renal biopsy, maybe with the thought of assessing the disease activity or disease severity. Restart steroids, tacrolimus, and azathioprine. And the last option was cyclosporine in place of tacrolimus. So most of the students had marked medical termination of pregnancy. That's what I heard from the students. But no, that is not the right answer. I've gone through various guidelines from the obstetric societies, from the rheumatological societies, as well as the nephrological guidelines. And no guideline specifically mentions or focuses on medical termination of pregnancy. There are some important recommendations. In the sense, one important recommendation is that patient should be in remission for at least 6 months. Okay, if there is history of disease activity in the past 6 months, if there is history of ongoing proteinuria, if there is hypertension present, if the patient is currently on medication, these are all pointers which are associated with bad obstetric as well as the pregnancy outcomes and as well as the bad fetal outcomes. But once a pregnancy has occurred, whether accidentally or because of unawareness of the lupus disease, once a pregnancy has occurred, definitely there is high risk of lupus flare and the outcome is not that great. But I have not come across any guideline which specifically recommend that we should push the patient for medical termination of pregnancy. Most of the guidelines talk about how do you tide over the crisis. Okay, renal biopsy anyway doesn't have a strong role right now. She is a known case of lupus nephritis, and I don't think we should be considering a renal biopsy at this juncture. So I would be thinking of these two options: restart steroids and tacrolimus and azathioprine, and cyclosporine in place of tacrolimus. Okay. So to address this question, we have to understand some basic things about the pregnancy and the safety of drugs. Okay. So this patient, we have agreed that she is going through a lupus flare. Right. So the drugs that are safe in pregnancy, that includes glucocorticoids. Okay. When we talk about glucocorticoids, I will tell you one important point right now. Glucocorticoids, if you are treating mother, right, then we are using the non-fluorinated glucocorticoids because they don't have a great transfer across the placenta. In fact, prednisone and prednisolone, right, they have a minimal transport across the placenta, and the fetal blood levels will be usually 1/10 of the maternal blood levels for this prednisone or prednisolone. On the other hand, if you use fluorinated steroids like dexamethasone or betamethasone, they have excellent transfer across the placental membranes, and they can achieve 30 to 40% of the maternal plasma concentration in the fetus. So if you are giving steroids to address a fetal problem, you can use fluorinated. That is why we use, for the lung maturity, we use dexamethasone, right? But when we are addressing mother, right, we should avoid fluorinated. We should stick to prednisone or prednisolone. So in that case, glucocorticoids are considered as safe. Hydroxychloroquine, its safety has been established time and again. It can be used in pregnancy. So we use that drug when we talk about the rheumatoid arthritis in pregnancy. So in SLE in pregnancy, you can consider using this. Okay. Then azathioprine and the calcineurin inhibitors, tacro and cyclo, right? These are also considered reasonably safe with the experience, particularly with respect to transplantation, right? Renal transplantation and pregnancy. We have experience about these drugs, and these are considered reasonably safe, especially when you use it second trimester onwards. So these are considered safe. What is considered as an absolute contraindication, absolute no-no in pregnancy, is methotrexate and mycophenolate mofetil. These, most of the authorities, most of the guidelines recommend these as absolute contraindications during pregnancy, right? So in this case, all I want to do is, okay, whether you consider flare or active lupus nephritis. If it is flare, okay, we would be thinking of pulse steroids. If not, anyway, the regular steroids plus the immunosuppressant. So for immunosuppressants, we have to make a choice based on these observations, right? So mycophenolate mofetil is something that I want to withdraw in this case, and I would be considering the other options, right? So the patient was on mycophenolate mofetil. This will be withdrawn. Steroids we can continue. Tacrolimus we can continue. Okay, now addressing the option D. The option D talked about substituting cyclosporine for tacrolimus. So the studies have shown that there is no great difference in terms of the obstetric outcomes, in terms of the teratogenicity between these two drugs. That is what the experience we have from the use of these drugs for last couple of decades. So because the patient was on tacrolimus, I think it doesn't make any great sense in just replacing cyclosporine. Even if you go by the spirit of this option D, right? It only says replace cyclosporine with tacrolimus. Even if there are some studies which show that cyclosporine is better tolerated in pregnancy in comparison to tacrolimus. I don't know, I have not come across such study, but even if such thing is there, right? Then also option D is not the right answer, because main thing we had to address here was mycophenolate mofetil. We had to take that off, right? So that is not satisfied in option D. So we are only left with option C as the right answer, right? So according to me, this is the right answer. Restart steroids, yes, we have to. Tacrolimus we can continue, and we can introduce azathioprine, right? I told you that is considered as safe, right? So mycophenolate mofetil can be taken off and azathioprine can be added. So for me, option C is the right answer. But obviously, if the wordings are twisted or wordings were not exactly like this, then the right answer might differ, right? So I make that disclaimer before we move on to the next question. Okay, so this is the next question. Class 1 indication for plasmapheresis in drug-induced TMA, right? This is one area which I am really not very much familiar with, or I have not dwelled deeper into that. So just let me give you the right answer. I have spoken to Dr. Ganga, who is our nephrology faculty, and she has gone through the latest literature available, and she says ticlopidine is the right answer for this, right? So from my side, I want you to remember the causes for the drugs which have been implicated in causing the TMA, right? So that includes mitomycin C, quinine, interferon alpha, ticlopidine, clopidogrel, bevacizumab, levoflox, alemtuzumab, and gemcitabine. These are the drugs I particularly want you to remember. And for this question, the right answer is ticlopidine. I will definitely do one more quick video on this topic when I dig deeper and collect little more information. This is the next question that appeared. This is kind of an anticipated question. Type 2 cryoglobulinemia is characterized by monoclonal IgM, polyclonal IgG, both A and B, and polyclonal IgM, right? So cryoglobulinemia basically means what? You have circulating immunoglobulins, IgG class most commonly. You are circulating immunoglobulins, and the circulating immunoglobulins precipitate on exposure to cold, and they redissolve on exposure to warmth. This is what we understand basically about cryoglobulinemia. So there are three types. The type 1, it is usually single monoclonal component, right? It is only one immunoglobulin that is circulating, and thus it is monoclonal. The typical causes for type 1 include Waldenstrom macroglobulinemia and myeloma, right? On the other hand, type 2 and type 3 are called as mixed cryoglobulinemia because they have IgM and IgG components, right? So in type 2, we have monoclonal IgM, mainly the IgM kappa, which is targeting it is against polyclonal IgG. And the typical example of a disease where we see this is HCV. So in HCV, type 2 is more common, right? More common is type 2 than type 3. Okay, so what is the most common type of cryoglobulinemia in HCV? Type 2, right? So in type 2, we are seeing monoclonal IgM, polyclonal IgG. So in type 3, we have both polyclonal. So we have polyclonal IgG, we have polyclonal IgM. That also a classical example is HCV itself. Right. So let us go back to the question now. Question was about type 2, right? So type 2 is mixed, so we will be having both IgM and IgG, and as I told you, it is monoclonal IgM against the polyclonal IgG. So the right answer is option C, both A and B, right? Okay, now this is the next question. I think this is also a pretty easy question for most of us. Patient with homocystinuria presents with DVT. Which of the following food item can prevent recurrent thrombosis? Right. So basic things about homocystinuria is all known to all nephrology aspirants, endocrine aspirants. So I will just take you through some important points. Homocystinuria, it is the most common cause for that is cystathionine beta synthase deficiency. Beta synthase deficiency. Okay. What is the function of this enzyme? This enzyme actually converts homocysteine to cystathione and cysteine, right? Subsequently, cysteine is formed. Now, when this enzyme is deficient, homocysteine levels start raising, right? And retrospectively, even the methionine levels will be increasing. So, patients with homocystinuria, patients with cystathione beta synthase deficiency generally have decreased cystathione levels, decreased cysteine levels, increased methionine and increased homocysteine levels, right? Okay. Now, this cystathione beta synthase is a vitamin B6 or pyridoxine dependent enzyme. That is why we supplement that whenever we are having a case with hyperhomocystinemia, homocystinuria, right? Okay, so that point is clear. Now coming back to the question. Obviously the right answer is option B. I think it's known to all of us, right? Pyridoxine supplementation whenever there is hyperhomocystinemia, homocystinuria, right? Okay. The additional points I want you to remember before we go on to discuss the further questions is that the differentiation between homocystinuria and Marfan syndrome is a very, very important MCQ topic. And so for that you should be aware that homocystinuria patients also have the tall stature and a Marfanoid kind of presentation. So some subtle differences you should be aware about. So go through the books. There are tables comparing homocystinuria and Marfan syndrome. Definitely spend some time on that. It is also an important topic. Okay. Clinical features wise, we can divide them into 4 domains mainly, the most commonly affected domains. One is eyes, where patients present with ectopia lentis, right? And ectopia lentis is one MCQ point which helps you to differentiate between Marfan's and homocystinuria. So you may be getting even image-based questions from this point. Like they will tell you that this is a particular patient who is tall, Marfanoid habitus, and this is the image of his eyes. Tell me whether it is Marfan syndrome or tell me whether it is homocystinuria, right? Skeletal system involvement, yeah, this is what we were talking about, right? Marfanoid habitus. Then increased risk of thromboembolism, that was what the question was talking about. And yes, homocystinuria can cause mental retardation. So patient may be associated with intellectual disability. Okay. And also remember that all 4 domains need not always be affected. You may have patient with only one domain being affected. You may have a homocystinuria patient only presenting with recurrent thromboembolic events without intellectual disability, without the ectopia lentis. So that can occur. Okay. Now before we wind up, right, this is one point I want you to note. You can go through the image here, and what you notice here is there is definitely subluxation of the lens, what we call as ectopia lentis. Notice the ectopia lentis. This is the lens, right? So the lens is subluxated towards the inferonasal side, right? On both the sides, the lens is subluxated towards the nasal side and inferior, right? That is very, very clear. This is typical of homocystinuria. On the other hand, in Marfan's, right, it is usually superotemporal. So superotemporal subluxation occurs in Marfan's. Atypically, yes, in patients with homocystinuria also, sometimes you may see superotemporal or other kind of subluxation, but classically it is inferonasal, right? So this is the one important point to differentiate between the Marfan's and homocystinuria. Okay. So here is the next question. AKI marker not suggestive of tubular injury. Well, this shouldn't have been a very difficult question. We are all familiar. Kim, NGAL and cystatin C are markers of tubular injury. Osteopontin is actually produced by fibroelastoblasts and osteoclast and osteoblast. It's more of a bone related substance rather than the kidneys, and it has been known to play some important role in pathogenesis of chronic autoimmune disorders. So it is a marker of malignancy, it is a marker of chronic diseases, it's a marker of chronic autoimmune disorders. So this elevation is not primarily a marker of tubular injury. So the right answer for this question is simple and straightforward, that is osteopontin, right? Okay. So with that, we will conclude this session, guys. I will be coming out with more videos once we have more collection of questions. I know some of the simple and easy, straightforward questions we have skipped. We have taken up mainly those questions which were a bit controversial or which were a bit difficult for the standard Harrison follower. And in the subsequent sessions, we will be addressing even the simple questions that appeared in the read, so that you are aware about the topics that are being recurrent. Okay. So the take-home messages are very clear, right? Regardless of whether you are preparing for NEET SS or INI SS, the take-home message is prepare with the eye for details on the epidemiology, right? That is going to become a very, very important message from my side. Spend more time on the epidemiology rather than some very, very rare named signs or named manifestations. Epidemiology, that will help you in making decisions, right? So when the story talks about something, you know that it is particularly more common in males or females, that gives you an idea about how to go about and how to reach the diagnosis in a particular question. So epidemiology is something that we should be paying attention to, right? So this is one important take-home message from my side. Epidemiology carries a lot of weightage. Then the second take-home message from my side is tables. Right? Actually, most of the standard textbooks, the tables are a beautiful summary of the whole chapter. So even if you just scan through the tables after you have done 1 or 2 rounds of reading, right, you can quickly revise that. So spend as much time as possible on the tables, and also frame your own MCQs from the tables. That will help you to retain and reproduce the stuff in a better way, right? That is the third message. Third take-home message is images. So what we have observed in the INI SS as well as the NEET SS, recently concluded NEET SS, is that most of the images that appeared in the exam were picked up from the internet, right? So they were not picked up from the standard textbooks. Maybe the boards are worried about the copyright issues or something. If they pick up from the standard textbooks, they may sue or something like that. So images are picked up from the internet. So whenever you read a particular sign or a particular image, say for example, you're talking about lupus nephritis pathology images, right? Make sure that you spend 5 to 10 minutes on the internet seeing the images that are available there, because one of that might appear in your examination, right? So images, internet. So please note this point. Okay. Now the fourth and probably the most important point. For INI SS, Harrison alone is absolutely inadequate. We all know that, but I'm again reiterating those who are thinking that I can crack an INI SS if I have a very thorough understanding of Harrison, because of late, the amount of information that is getting accumulated, right? Harrison cannot really keep pace with, or Harrison cannot be a 10,000 page book, right? So Harrison is not going to accommodate all of that. So you have to look at the SS specialty books for your INI SS. Can we address NEET SS with Harrison alone? Yes, definitely yes. But again, there is one important point I want to tell you. The point number one is, okay, in the subsequent exams anyway, for the 2022 it is going to be medicine based, so Harrison will become the gold standard. But even if they are following the current pattern, then also Harrison can help you to get a rank where you will be safely placed to get a seat, but you want to exercise great flexibility in terms of your choices, right? Then you need to have single or at best rank within 20 or 25 for most specialties. That score may be really difficult with Harrison alone, right? So you have to bank on the super specialty books if you are planning for a rank within 25 of whatever your specialty is. For nephro, definitely you can't get within 25 with Harrison alone. I think Harrison doesn't really treat it well. I think Harrison treats well endocrine, Harrison treats well neurology to some extent, but nephro, no, it's not a great treatise on it. So you have to bank on the SS books. Fee Heli, I think when I went through all the questions, right, most of the things could be addressed from Fee Heli. It's a good source, and you can just supplement it with Brenners. And one more, the fifth thing I want you to note is that particularly the diseases which are very common or they are hot topics in your specialty. For example, if I'm talking about rheumatology, SLE, rheumatoid arthritis are hot topics, right? So for those topics, even the standard textbooks are a bit outdated because the edition is released once in 2 or 3 years. So go through some review articles which are published in the last 2 years' time, not older than that, right? 2020, 21, at worst 2019 review articles for those diseases. That will throw a lot of light because the stuff that is covered in the review articles will become part of the textbooks in the subsequent editions. But what happens is sometimes when the exam is just around the corner, the next edition of the books comes out and the examiners pick up questions from the latest information available in the books, and then you will be at serious disadvantage. You would have really spent a lot of time preparing yourself from the standard books, but still you are at disadvantage because you are not updated, right? So better start updating yourself. Don't rely just at the level that books are given, right? Okay. So with this, I wish you all the best. We will again connect on the next video with the remaining questions of nephrology recall, right? Thank you guys.